Economics on Health and Aging and a senior fellow in the Stanford Institute for Economic Policy Research at Stanford University and the Stanford University School of Medicine. He holds an MD and a PhD in economics and earned both degrees at Stanford. He's published 135 articles in top peer-reviewed scientific journals in medicine, economics, health policy, epidemiology, statistics, law, and public health, among other fields. To my immediate left is Dr. Robert Redfield. Dr. Redfield was the director of the U.S. Centers for Disease Control and Prevention from 2018 to 2021. After he left the CDC, Dr. Redfield served as a public health advisor to Maryland Governor Larry Hogan. A virologist, Dr. Redfield co-founded the University of Maryland Institute of Human Virology and served as chief of infectious diseases and vice chair of the Department of Medicine at the University of Maryland School of Medicine. He's an infectious disease consultant at the Greater Baltimore Health Center and is a senior visiting fellow in biosecurity and public health policy at the Heritage Foundation Asian Studies Center. He received his Bachelor of Science from Georgetown University and his MD from Georgetown University School of Medicine. And last but not least, to the extreme left, which does not actually describe Ryan, is my colleague from the Cato Institute, Ryan Bourne. Ryan holds the R. Evans Scharf Chair in the Public Understanding of Economics at the Cato Institute. Before joining Cato, he was head of public policy at the Institute of Economic Affairs in the United Kingdom. He writes a weekly column for the Times of London. He wrote the book Economics in One Virus, which examined the response to the COVID-19 pandemic from an economics perspective, and most recently wrote the book The War on Prices, both of which are published by the Cato Institute. You could purchase Economics in One Virus outside where you're registered. Ryan holds a Bachelor of Arts and a Master's of Philosophy and Economics from the University of Cambridge in the United Kingdom. And I want to start things off by asking you, Jay, since you were actually a major star of the film, did the film leave out any important details of your experience during the pandemic? And why do you think there was such a concerted effort by the academic medical establishment to dismiss your findings that suggested the virus was less deadly and the deadliness was more age-related?
Well, I didn't leave anything out. I mean, it's been 4 years of I mean, it was...
You just gave him PSD.
Yeah.
PSD?
Actually, as I was watching the film, one thing that occurred to me, and as I was sitting next to Dr. Redfield, that it's tremendously difficult to make decisions and recommendations in real time when you're seeing the uncertainty around it. And the film, I think it's an amazing film, business. I'm just touched by it. But I think that the hard part is in the real time, you don't know what's right or true, and so you want to do things that benefit the public, but you don't know exactly what the right thing is, and it's tough for scientists, it's tough for leaders, and the film got this got this across. But the thing that struck me most during the pandemic was how that the scientific community and the leaders of the scientific community, people like Tony Fauci, made it much harder on themselves by not allowing and embracing the kind of normal scientific ebb and flow that you would normally see on issues, right? By allowing outside voices, by allowing people to dissent, and rather than trying to demonize or destroy the people that were trying to do that, they'd embrace that. It would have been a very different. I mean, there would have been tremendous harm. It would have been mistakes anyways. But I think that people like Tony Fauci, I almost feel sympathy for him because he made his life so much harder as a leader by not embracing free speech, by not embracing dissent.
Bob, your name came up a couple of times in the movie, so I think you should have the next chance to speak to what was said about you.
Well, Scott Atlas and I were not really on the best of terms there, so I'll just leave it at that. But I do respect him. I always felt the basic premise of the Great Barrier Declaration was right on target. I mean, I did some of the early work at CDC when people were saying children weren't infected. The highest risk group in the population we had were 5 to 10-year-olds, and the one above that was 10 to 15-year-olds. They were always infected at the highest rate. They just didn't get symptomatic. They didn't get sick, and as was stated, they had a very limited mortality. So I do think the point that Jay and the Barrington group tried to say, it wasn't really about herd immunity. It was about targeted intervention to protect the vulnerable. And that's really what needed to happen. It was a huge mistake to try to extrapolate that to the population at large. The second thing that I did argue very much against was any type of mandate. I think in public health, when you mandate somebody to do something they don't want to do, all you do is reinforce in them the hesitancy to do that. So it was a huge mistake now to go for vaccine mandates, and unfortunately they were expanded. And I will say, you didn't notice, but on the press conference that they, and Jay was sitting next to me, the press conference when they laid out the lockdowns, you'll notice that there was somebody not present because I was not an advocate of that at all. You don't know, maybe you heard me talk on television. They tried to keep me off television. Actually, the secretary didn't approve my ability to talk on television, which was awkward since I was only the CDC director. But the point is that I was a strong advocate, and you'll find this in some of the clips from some of the states. When I finally figured out how to get on television was to go to the states and do local TV, where I could do that, and then lo and behold, it gets picked up on the internet, and it's all over the place. But I always argued that the public health benefit for K through 12 was to stay in school. All right, closing the schools, I argued back then, was not in the public health interest of the kids K through 12. Kids were at risk of getting COVID at the dinner table more so than in the school. And some school systems listened to me. The North Dakota, Doug Burden listened to me. Arkansas listened to me. And I was lucky that the Archdiocese of Baltimore, where I happened to live and where I had a number of grandkids, they listened to me, and we kept those schools open. I was actually given an award for keeping the schools open, and I was very proud of the fact that the kids in the Archdiocese of Baltimore had the highest scores they ever had in math and English when they took them, and the public schools had the lowest scores they ever had. So very, very sad public policy. But that wasn't an open debate among all of us. That was a private discussion between Fauci and Birx and the president and the vice president to really buy into lockdown. So again, it was another mistake. In retrospect, the Barrington Declaration was really kind of right on. And I want to just get a lot of admiration for Jay and his colleagues who took a lot of abuse. I took the abuse, not so much on that, because even most of you probably don't know that I was an advocate against the closures, because you wouldn't get that from Scott's comments. But I took the abuse because I became a firm advocate in the middle of January that the most likely etiology of this pandemic was a laboratory in Wuhan. And I remember when I made those points of view, they were highly discredited to the point of death threats. I was telling Jay, the Baltimore Sun had their paper after Sanjay Gupta published my interview where I said I thought the virus came from the lab. The next day, the Sun wrote articles saying that I was a racist, an Asian racist. But it didn't stop there. The state of Maryland Senate and the House both passed resolutions censoring me as a racist. I've asked them to rescind those, and even Hogan, when I worked for him, I asked him, could he get them rescinded? He told me that was a bridge too far. They were never going to admit that they were wrong. And then they asked Hogan to fire me, because I was a senior public health advisor for him in the state of Maryland. And Hogan, whose wife was Asian, his kids are Asian, his grandkids are Asian. Hogan actually said it would be very difficult to fire me because when I decided to work for him as a senior public health advisor, I only had one requirement, and that was that he didn't pay me. So since he wasn't paying me, he didn't find it was in his interest to fire me. But it's very sad how rapidly people who just disagreed with you immediately wanted to classify you as a racist. And the last thing I'll say on this, maybe I'll go to the Cato. I wrote a nice book. I had about a 60-page, frame to get my book, and I got a lot of interest in my book. St. Martin's Press is where I wanted to do it, but I had the other ones, Random House and others. And at the end of the day, all the main publishers rejected the book on one condition. They thought it was totally inappropriate that I suggested the virus came from Wuhan laboratory. Now, I think the sentiment's changed. I think I'm going to put my book out in 26, and by then I think you saw Radcliffe on there. I think you're going to see the intelligence community, probably after the election, there'll be a revisiting of their point of view, and I think you'll see consensus among all the intelligence community that the etiology of this epidemic was the lab.
Ryan, what would you say were this film's most important revelations as an economist?
It was a real trip down memory lane, wasn't it? Some of those crazy times. But I think I'm going to make 2 quick points. I love the title of the movie because, there have been some economic efforts so far to try and, or both during the pandemic and post-pandemic, to try and calculate the balance of the costs and benefits of lockdowns. It's something that Cato has kind of advocated all the way through the pandemic and trying to make sure that people are recognizing that there are trade-offs in life. But one of the things I really liked about the movie that has not been covered by the economics profession really is that when they tended to do those calculations, they tended to weigh calculations of the public health benefits of mitigating the virus, whatever that may be, whether we agree with the numbers or not, against some sort of measure of GDP or unemployment or whatever else. And what that leaves out is a massive chunk of value, which is the value of us living our lives and engaging in lots of social activity, leisure activity. How do you put a valuation on the ability to attend a funeral of a loved one? It's almost incalculable. Now, clearly, it's very difficult to weigh up those subjective evaluations across a population, but assuming that that value is zero in the calculations is a real misstep by the economics community. The second point that I'll just make, and I know we're going to get into more specifics about policies later, is that I think if you take a kind of step back and go back to February, March 2020, one point that was perhaps not made is we didn't just see what had happened or the perception of what had happened in China and some of the struggles in Italy and New York, but particularly on the East Coast cities, I don't know so much about the rest of the country, there was a lot of voluntary social distancing at the time. I wouldn't go as far as calling it a voluntary lockdown, but there was a lot of that going on already. And so to a certain extent, in that first spring at least, politicians were, in a sense, kind of codifying what some of the people most worried for the virus were doing already. And I think where I really agree with Jay, and he made a really important point in his first answer, is there was an unwillingness on behalf of public health officials to talk about the high degree of uncertainty of the effectiveness of these policies at the time. Very definitive statements about what we should do and the effect that it would have. And then as the economy started reopening, I think that that unwillingness initially to outline the uncertainties and treat us like adults meant that people were in very, very entrenched positions about what they thought would work or didn't work. So even as we got more evidence about some of the trade-offs, even as it became clear from the data that children were at far lesser risk than adults or older people in particular, there was an unwillingness, a stubbornness to adapt policy to those trade-offs. So I can kind of give politicians a bit of a pass for some of that spring 2020 because there was a lot of panic around, a lot of uncertainty. It was the unwillingness to kind of experiment and change after that I thought was a really inexcusable failure.
I'd like to say, as a clinician, one of the points of your film that I thought was important and I would actually have liked to see a little more discussion about was the section where the critical care specialist lost his board certification because he was prescribing ivermectin. Now, the evidence is now pretty clear that ivermectin doesn't treat COVID-19. There have been some good randomized controlled trials on that. But at that particular point in time, when we didn't have any known treatment, the vaccine wasn't developed yet, as long as the patients are given informed consent and they're informed by the doctor, look, there's some anecdotal evidence suggesting this medicine may help, and they could present a plausible rationale for why it may help. That's called off-label drug use. Roughly 20% of drugs that are prescribed in this country are for off-label uses, which means the FDA didn't approve them for that use, but the FDA is okay with that. And a lot of times that it turns out that those drugs really didn't work for what they would be used off-label for. But sometimes it leads to great discoveries, like, for example, the drug thalidomide that was originally prescribed for morning sickness and during pregnancy, of course, caused horrific birth defects. But later on, it was discovered to actually be helpful to treat leprosy and multiple myeloma, which was not what it was developed for. So I really, to vilify doctors who were willing to try things, providing they let their patients know that, this is only anecdotal, it may not work, there may be some risks. I think it was really counterproductive to do that. And that was, again, part of the process of shutting things down.
Can I comment on that? Because the question of whether, say, ivermectin works, or hydroxychloroquine works, or metformin works, or just all of these are questions that are not actually political questions, although they turned into political questions. They're actually questions that are resolved by randomized trials, and they're randomized trials that should have been run in 2020. It's not that we lacked for patients. It's a signal failure of the NIAID, Tony Fauci's agency, for not sponsoring very rapid studies on each of these things. Because had we had randomized trials in 2020, it would have entirely depoliticized the question. You saw in the film people taking veterinary doses of ivermectin. The reason they did that is because they couldn't go to their doctor, because the doctor would be, essentially, they'd lose their license if they prescribed ivermectin. And there were overdoses and deaths from taking veterinary doses of a drug that has normal human doses available. If it had been prescribed by a physician, that those deaths wouldn't have happened. And so I think the question of uncertainty there, it was a decision made to not run those trials as rapidly as possible in 2020. In fact, the ivermectin trial, Active 6, that the NIAID sponsored, didn't actually get finished, didn't report out results until 2023. That's a policy decision. What do you support for the research dollars that you put in? This was the main subject of research. I don't have a good reason why we didn't do that. That would have solved all the politicization, a good randomized trial in 2020.
I think some of it, too, is it's going to be important, and we'll talk maybe more about it later, because obviously I'm of the view that there's another pandemic coming, and it's going to be quite problematic. So hopefully we'll learn some lessons from the last one and not make the same mistakes. But I do think there was a huge overemphasis by the leadership of NIAID on the path out of this pandemic was vaccine development. And the truth is, when it comes to respiratory viruses, flu and COVID, our vaccines are at best 50% able to impact infection rates. And as you all know, the COVID vaccine didn't get approved for impacting infection rates. It really modified disease, particularly in those that were high risk for disease. So I think there was a bias, a terrible bias, and unfortunately there still is that bias, that the path out of COVID, the path out of the future pandemic, which is likely going to be a bird flu pandemic, that path is vaccine development. And again, I'm a big advocate. I spent most of my career in vaccine development, but I'm going to tell you the path out of these pandemics is antiviral drug development. And that's the path out of the COVID pandemic and the next pandemic.
Do you think that perhaps the reluctance to hear anybody suggest a medical treatment for the virus was because, as Jay alluded to in the film, that it might jeopardize emergency use authorization of a vaccine were it to get developed?
I don't know the answer to that because, remdesivir came across. We did get that approved. We did get that over the goal line. I just think that the people that were dominating the policy were vaccine related. I was on the Operation Warp Speed board. I argued very aggressively on that board along with Ambassador Birx, who actually was my deputy for many years. We argued that, Tony and Collins argued that NIH would take care of developing the vaccine. It would take 3 to 7 years. but just give the $15 billion to them and they take care of it. Debbie and I argued that the private sector will develop the vaccines and get the military to do the distribution. Luckily, we won that argument. And as you know, we had 3 private sector vaccines within 8 months, and then the other 2 that we invested in got approved after the first of the year. But the vaccine was where the emphasis was. We also argued that we should have an Operation Warp Speed for antiviral drug development, and that never happened. And what happened at the end of the day, I left office January 20th, 2021, when Biden became president. What happened was they decided to have an antiviral drug development program. You probably know this, and Biden put $2 billion into it, and they gave all the money to NIAID. The money needed to go to the private sector. It's the private sector that develops these products, not NIH.
Vanessa, what do you think about what you've heard so far?
Well, the point of including the ivermectin segment in the film was not whether ivermectin worked or not, but that it had been a very, very safe drug for many decades, Jay, as you pointed out, and the fact that an organization such as the FDA and also Health Canada warned doctors against using ivermectin as a COVID treatment, for me signaled that you have a large organization that is infringing on the sacred doctor-patient relationship, where most doctors should be free to prescribe any drug they want off-label to their patient, given, and especially in this case, given the safety of ivermectin. I think there was the same issue with hydroxychloroquine early on in the pandemic, where I believe it was President Trump at the time who was treated with hydroxychloroquine. And were we dealing with the same issue there?
Yeah. And I took a lot of criticism because as CDC director, one of the things I have is the MMWR, which is a weekly publication. And I instructed the paper, the editors, that I wanted an article published on everything we knew about hydroxychloroquine, right? You know, just because if people chose to use it, I wanted people to know what we knew, what doses had been used, what was happening, what was the toxicity. And I remember CDC was very angry at me because they said, you know, you shouldn't publish that. And I said, I'm not recommending it, but I'm also not recommending it. You know, I mean, I'm letting the physicians and patients know what it is we know. I agree with you very much what you said. And I'm very involved now in my clinical practice. I still do 1.5 days a week clinical practice. And my clinical practice now is about 80% long COVID. And I have a lot of patients that are very, very sick from long COVID. It's really quite substantial. And I will tell you, most of the patients that I'm treating with off-label drugs, all right? But the same thing you do. I'm explaining it to them. It's informed consent. One of the drugs that I use has been in clinical medicine for more than 80 years. There's plenty of safety data on that drug. One of the other drugs I use is an old age drug that I used to be a world's expert on. But the fact is, when people are very sick, and I mean really sick, we physicians will work with patients to try to do what we can do. And one of the things we do is use off-label drugs. I thought it was very dangerous for the FDA to be so heavy-handed. And I thought it was extremely dangerous for state health licensing organizations to go after doctors' license. Totally inappropriate.
Ryan, I saw you kind of perk up when Bob said that the money should have gone to the private sector, not to the NIAID. So you'd like to talk about that?
Yeah, I mean, from a broad societal perspective, something like a pandemic coming along is incredibly costly. Not just to economic activity. I mean, even in countries like Sweden that didn't do lockdowns, there was initially still a fairly big downturn. So, it's costly from that perspective, but also lives are incredibly valuable. So to the extent that we can kind of save lives through these technological and medicine developments, all the better. And I think, if we're going to have a bit of kind of constructive debate here, one bit that I slightly disagreed with Jay on the movie, actually, he kind of said, one of the reasons we shouldn't have had attempted lockdowns was that, we didn't have an empirical evidence base, we hadn't done a randomized controlled trial, which is true. And that was a massive kind of intervention to go with without that sort of data. But a pandemic is so costly that you almost want a lot of experimentation. You want a variety of different approaches. And so, a lot of the things that kind of Cato published through the pandemic were about some of the failures to allow private testing quite early in the pandemic. The fact that we didn't have operational diagnostic tests in that first wave meant that we didn't really know where the virus was for a number of weeks, and as a result of that, we ended up with blanket policies when actually much more targeted policies could have been implemented. The FDA then held up rapid testing, which, not perfect, but they can help people mitigate that trade-off, mitigate risks. With vaccines, should we have had human challenge trials? Could that have got the vaccines into the broader public a month earlier? A month earlier, when you're talking about $16 billion a week, is pretty significant. So, you saw me perk up, Jeff, because I think there's a hell of a lot of pent-up things, technological developments, advances in technology that could have been achieved had we actually kind of taken a step back and taken the shackles off a bit.
You want to respond to that?
Sure. So, there's a lot I agree with there, but let me talk about it from the perspective of decision-making under uncertainty in March of 2020, right? So there's this massive thing happening. The principle that everyone heard at the time, I'm sure you remember, was the precautionary principle, right? The idea that we don't know how bad this thing is going to be, and therefore we ought to lock down just in case, right? As an economist, I'll take my doctor hat off, put the economist hat on. As an economist, I think the key thing is what the precautionary principle advises you is you don't know some things, and you're allowed to assume the worst about those things. Like in March of 2020, I didn't know the infection fatality rate. I hadn't done a study yet at the time, and there was a lot of uncertainty about that. I think if you're a decision maker, you're allowed to say, okay, let's assume the worst about this thing. You're not allowed to ignore things that you do know. If you close schools, you're going to harm the health and well-being of our children with damage that will last a generation, that you knew. You know that the living circumstances of the poor, especially the poorest people worldwide, are such that a lockdown could not be abided by for very long. People in the slums of Mumbai did not voluntarily lock down. They locked down because they were forced to lock down. That same true is in the United States. Only 20 or 30% of the United States workforce has jobs that can be replaced over the long term by remote jobs, right? So the voluntary lockdowns are only for the laptop class, right? That's just a known. You're not allowed to ignore the harms of the policies you adopt. So you do a cost-benefit analysis with uncertainty. You assume the worst about the policy, about the disease, the harm that you're mitigating, you're trying to mitigate. You're not allowed to assume that the policy is going to work, and you're not allowed to ignore the harms of the policy when you adopt the precautionary principle. I think had that principle been really embraced, honestly embraced, we wouldn't have locked down. I think we would have done that calculation and said it's not worth it. It's not, because the mitigation policy, the lockdown, as a social scientist, it offended me as a professional social scientist, because the idea that the world could protect itself was such an elitist idea, and it seemed obvious to me as a social scientist who studies socioeconomic status and health and health and well-being in poor countries, that there was no way a lockdown could work for very long, if at all.
To your point, Jay, I think, to me, one of the most revealing parts of the film was Dr. Francis's quasi-confession at the end, which was the last box. the film where he does say that the health policy mindset doesn't really take into account all of the collateral damage, all of the economic damage, the mental health damage. That the health policy mindset is concerned about saving lives. I may be misspeaking. Is it a health policy mindset or is it a health?
That's a Francis Collins mindset.
Maybe a public health mindset.
Yeah.
I think that's what he meant.
I think
Public
he
health
meant,
mindset.
he meant it as, it's the NIH mindset.
Yeah.
Because when you think about it,
Yeah.
actually, your public health recommendations should be holistic like that.
Yeah, I mean, that's what always drew me to public health. Like WHO's notion of health is not just prevention of a single disease. It's the well-being of the human, right?
But Dr. Collins did recognize
He did.
in that interview that the public health mindset, which looks at only saving lives, to the exclusion of all other damages, he said that was unfortunate. That there was a preponderance of that mindset during the COVID period.
I must say, some of it also had to do with a lot of the fear that was inflicted on the general population, largely by some of the public health establishment and the media. So as a general surgeon, we saw this huge increase in people coming in with surgical emergencies like appendicitis or ruptured diverticulitis, things that I deal with, or even malignancies in advanced stages that haven't seen in years. We catch them much more earlier because people themselves were putting off going to the emergency room because they were afraid to get COVID.
Some of that fear was, the groundwork for it was set. If you go back and look at the original Wuhan pandemic, many of you may or may not know the original mortality rate of the cases they identified was over 8%. Now, it's not because COVID had an 8% mortality, it's because they overwhelmed their health system. In New York City, when they started their epidemic in March, April, we had a 7% mortality of the cases that presented. Again, not that they were dying because of COVID, they were dying because the health system could no longer function effectively. And so I think there was an overestimation. Some of that was one of the big mistakes that was made from the beginning when it was decided that this was a SARS-like virus. Well, this virus is nothing like SARS. SARS, had a 7 to 10% mortality. It really didn't go very well human to human. This was not a SARS-like virus at all. But when they went into that model SARS-like and they saw Wuhan with an 8 to 10% mortality, they're thinking this was SARS-like, and it was really nothing to do with SARS. This is a wholly different virus. It's, as Jay pointed out, probably had an overall, 0.2 to 0.6 mortality, depending on what age group you're looking at. If in young children, it had much less than that. It was just totally misclassified because, and that led to a lot of mistakes. Not the least was the public health mistake. And I wanted to say this one thing, because many of you may not know this. When I first heard that there was 27 new cases of unspecified pneumonia in China on New Year's Eve in 2019, I called my counterpart, George Gao, who's the head of CDC in China. And we had a very good relationship, and he was a very good coronavirologist, actually. And I asked George, what's going on? He says, I have 27 cases of an unspecified pneumonia that's not SARS and not flu, and they all came from the wet market. And I said, well, George, help me out. What's your case definition? And he said, well, it's unspecified pneumonia that's not SARS and not flu from people who came from the wet market. I said, well, George, then by definition, everybody came from the wet market. You need to get away from the wet market. That was part of the SARS mentality. Go away from the wet market and see what you see of unspecified pneumonia. And 2 days later, 3 days later, he called me back. And he said, Bob, we have hundreds of cases that had nothing to do with the wet market. That's what's particularly bothersome about the proximal origin paper, because we now know that the transmission of this virus started in Wuhan somewhere between August and October, right? We know that this epidemic started long before the wet market. We know it had nothing to do with the wet market. The CDC director of China says it had nothing to do with the wet market. And yet we have these scientists are trying to say that this somehow epidemic started at the wet market, or we have, you know, the Atlantic magazine and the New York Times that say it came from raccoon dogs. No, this virus really did emerge not from the wet market and really started much earlier. And the other thing he said, and it was a mistake, there was no human-to-human transmission because they saw no nosocomial infections among doctors and nurses and healthcare people taking care of the patients. However, they didn't think that there was a possibility there was asymptomatic infection. And the young people were the doctors and nurses and healthcare professionals. And had they tested them, the last thing I'll say on this, just for some history, I diagnosed the first case in the United States in Seattle. I think it was January 2020th or 2021. And over the course of the next 4 weeks, we diagnosed not imported cases from repatriation of our citizens in China, but the individual citizens that were coming back. We diagnosed 14 cases, right? All the way through the second week in February. I had CDC and the Public Health System of America evaluate the contacts. We evaluated over 800 contacts. Only 2 of those contacts were shown to be infected with COVID-19. So based on what China told us, the CDC, and based on that data, we said it doesn't look like this is very infectious. Yeah. But how did we diagnose those contacts? We diagnosed them by bringing them in and taking a history. If they weren't sick, we let them go. If they were sick, we tested them. If we had tested all 800 people, we would have figured out early February that this is a very highly human transmissible virus. It wasn't until the Diamond Princess that Debbie Birx and I said, wait a minute, we got this all wrong. This is largely an asymptomatic transmitted virus. We need to shift the focus to basically expanded diagnosis, to basically, from a public health policy, find out where's the silent epidemic. We got to move away from the symptomatic disease. But unfortunately, we didn't have any support from the private sector, because you may or may not know, when SARS came, the private sector developed a test for SARS. And what happened? SARS went away. When MERS came, the private sector developed a test for MERS. What happened? MERS went away. So when COVID came, the private sector did not help us with diagnostics. The CDC test was never flawed, contrary to what the news says, and everybody, it was never flawed. It worked great when we developed it 7 days after the sequence was available. It works great today, all right? But the only mistake CDC made was when the states were complaining that they wanted to do the test themselves, they decided to produce all the primer pairs, and since they were sending it away from CDC, they decided to add a 3rd primer pair just to make sure they didn't have any false positives. Well, they didn't vet that 3rd primer pair right. And that 3rd primer pair was defective, and when we tried to validate it, it didn't validate. Nobody ever used that test, but it took us another couple weeks with the FDA. But we never thought CDC was going to provide testing for the whole medical community. We were providing it for the 100 public health labs around the country, and the medical community didn't provide the testing. Private sector didn't do it. We published the primer pairs. We didn't patent it. But what did the FDA do at that time? They said that they were going to enforce pretty aggressively against laboratories doing laboratory-developed tests. So all the molecular labs stayed on the sideline. Korea did it differently. When Korea had that imported case of MERS around 2016-17, they formed a partnership, private-public partnership with the private sector, diagnostic companies, to develop the MERS diagnostics. So when COVID came, they just pulled the lever, and that private sector company and the government made all the tests they need. And that's why Korea had all the tests. That's why Governor Hogan, whose wife's Korean, went over to Korea to get tests for the state of Maryland. A lot of interesting stories, you know, as you try to put this all together.
Ryan, I see there's a lot you'd like to say here.
Yeah, so I'd like to offer a bit of a criticism again of my economist friends, because a lot of economists actually denied the trade-off, and I actually think it's related to the Korea aspect that you're talking about, because a lot of people looked at Korea, which had this completely different regime where they were able to test pretty quickly and trace contacts and things, and thought because they had both good economic outcomes and low prevalence of the virus, that inherently there was no trade-off between shutting down parts of the economy to suppress the virus and economic outcomes, where of course they had a different technological framework, right, that allowed them to do that. So that just wasn't available in the US given the degree of community prevalence that we saw. But economists did blithely keep repeating this phrase that there's no trade-off between mitigating the virus and the economy. One very famous economist said on April 3rd, 2020, I won't say who he is because I've got a great deal of respect for him, that the recession and recovery would have the character of a rebound that hits Cape Cod economy every winter, or recovery in American GDP that takes place every Monday morning. And what he meant by that was essentially it'd be very, very easy to switch the economy off and switch the economy back on again. But of course, banning voluntary trades, banning the operation of supply chains, banning individuals kind of meeting to discuss new projects, that tears at the fabric of economic relationships and clearly has a big short-term cost. I mean, at one stage, about a third of output in this country wasn't being produced, output that we would have expected wasn't being produced as a result of shutdowns. But it also had long-term macroeconomic consequences as well, because as a result of the lockdowns and the politicians felt they needed to make everybody whole, we printed lots of money, we borrowed lots of money, and that combined with the fact that coming out of the lockdowns we had supply chain issues contributed to the highest inflation we've seen since the early 1980s. And that has all sorts of societal consequences, not least one presidential candidate at the moment talking through the media, floating the idea of removing Fed independence, or at least compromising Fed independence. So a potentially, huge economic consequence of this. Now, in my book, I kind of made the point that a new virus like this was always going to be costly. We shouldn't pretend that this wasn't a big deal. But there were better ways of managing those trade-offs, and we've kind of discussed some of them, so I won't labor the point again. We should have been trying to find mechanisms, solutions, therapies, ultimately vaccines, to try and reduce this sharp trade-off between short-term economic activity and people's health.
We're going to be going to questions soon, and so for those of you watching online, you could submit your questions on our Cato webpage or on Facebook or YouTube or Twitter. Use the hashtag Cato Health, and we'll also take questions from the audience. But before we do, I have one more question. I think I want to pose this to Bob, but then I'll invite anybody else to jump in. In October 2019, the World Health Organization published the non-pharmaceutical public health measures for mitigating the risk and impact of epidemic and pandemic influenza. And in that, in the section on travel-related measures, it stated, quote, entry and exit screening for infection in travelers is not recommended because of the lack of sensitivity to these measures in identifying infected but asymptomatic, i.e. pre-symptomatic travelers. Yet that's precisely what was recommended. And in fact, it persisted long after the public health agencies in most of the other countries of the developed world stopped doing that. I seem to recall it was as late as April of 2022, maybe, before you didn't have to get tested to return to the United States if you were in Europe.
It was actually in June, I think. And the reason I know this is because I had my wedding in the UK, and everybody was going to have to get tested to come back in. And Joe Biden removed the Biden administration removed the restriction on my wedding day, so everybody was celebrating.
Well, so would like you, the public health people, to speak to that.
Yeah, I'll be happy to comment on it. I think it is true that WHO had that perspective, and it is true that WHO was pretty aggressive in their commentary about the decision that we made about restricting air travel to and from China. And I will say, I think we have to be honest about the recommendations that we made. and not try to say, well, we didn't make it. I did go into the Oval Office to the president on January 31st, and I told the president that I felt we needed to restrict air travel to and from Wuhan, China, at that time, that there was a huge pandemic going on in China. China had locked down 11 million people, and I felt the cases that we had in those original 14 cases at that time, I probably had 6 or 7, they all came from Wuhan, China, into the United States, and I thought we had to limit that travel. Not that I ever thought we would prevent the introduction of this virus, but I thought we might be able to slow the introduction into the American public while we try to develop countermeasures, and it was all just a race against time. In March, I went back into the Oval Office because now I had more data, cases, and actually Santa Clara was some of the early cases, and New York City, I started getting these cases that had nothing to do with Wuhan, China. They came from Italy. They came from France. They came from Germany. And all of a sudden I recognized airplanes go from Wuhan into Europe and then Europe into the United States. And all of these entered. So by that time in March, we had already seeded the United States in multiple cities. And at that time, I was not of the view as we got into May and April that we're going to get any benefit from travel restrictions. And I won't tell you how many phone calls I got because we did have travel restrictions. So when the professional golf tour were going on, all these golfers, you know, would I give them exemptions so they could come in and play a golf tournament? People that were trying to get married, would we give them exemptions? So, but initially I did recommend to the president that we halt travel Wuhan, China in January 31st, and then also then into Europe in March. But by the time we got into May, I realized that you know, that ship had sailed. And whether or not we gained anything or not from it, I don't know.
Actually, can I make a comment about that and to tie it to something you said earlier, Bob, which I think is really, really important. Right? If the virus is released in human circulation at sometime between August and October 2019, in the Chinese authorities likely knew about that. The people in the lab probably knew about it right away, but the Chinese public health authorities more broadly probably knew about that November 2019. I mean, I'm not sure what the date, what the right date would be. Certainly by early December. Had they made that public, the decision making in the rest of the world would have been very, very different.
Very different.
Right? The nature of the virus, that it spreads asymptomatically, that it spreads by aerosols, it changes fundamentally how you think about policy. Right? A policy that's aimed at suppressing a SARS-1-like thing is going to be very different than I mean, you may decide that it's beyond us to suppress. In fact, that's basically what I decided after I saw the Santa Clara results.
You raise a really important point because one of the other challenges that we had with this pandemic, and I, as CDC director, I didn't realize it when I became the director, but after being there, I realized I worked very closely with the intelligence community. There's a lot of public health issues, biosecurity issues that are very much embedded. I think I spent more time in SCIF than I ever thought I would. But I will tell you that one of the real challenges was the lack of real-time communication between what our intelligence community ascertained, because they haven't analyzed it yet, and the public health community. We know now that in early September of 2019, 3 things happened in the Wuhan lab. It's all been declassified, or at least it's in the public press, so I can talk about it. We know that 3 things happened in September, early September, long before we knew about this new epidemic. The Wuhan lab deleted access to the sequencing data from all the coronavirus that they had done over the decades before. As Jay will know, highly irregular for scientists to delete that information. Second thing they did, which was also unusual, was the do-use lab. They removed the civilian leader and they put the military in charge of that lab. Also a little unusual, okay? But the third thing, and I did a lot of dual-use work and worked at Fort Detrick and maximum containment labs, The third thing they did that I think is really the bell ringing is they lent a contract to redo the ventilation system of that lab. So I think we believe in the intelligence community that's now in the public domain, and there hopefully someday soon there'll be more in the public domain. We believe that this pandemic probably leaked out of the lab, infected some lab workers sometime in late August, early September.
But my understanding was from the research that we've done was that a scientist who was affiliated with the Chinese military, Zhu Yusen, the scientist in the film who was allegedly thrown from the roof of the Wuhan Institute, the research showed that he had patented a vaccine for COVID in 2019.
I know the data. I'm kind of restricted in what I can say, what's in the public domain and what's not in the public domain.
I understand. This was research that was not original research on our part, but there was a report that the Senate subcommittee does have, and it is public. And I think it's under Senator Marco Rubio's file, and that's where we got. Yeah,
it's just an opinion. My opinion is that this lab was doing very purposeful research long before September and August, as you commented. That purposeful research was they were trying to develop a vaccine vector that could be used to vaccinate the vaccine military and the Chinese people and maybe beyond. And for that to be a useful vaccine vector, it had to be a couple things. One, they knew it had to be aerosolized, transmissible. We didn't need to use needles for everybody. They wanted to be aerosolized. The second thing they wanted to do is make sure it didn't make people sick, and that's why they knocked out the interferon response element in open reading frame number 8. So this virus has really been manipulated, so when you get it, you're more likely not to get sick. And the third thing they did with the open reading frame 8 is they changed the way in which the human immune system sees the immunodominant domain so that you could use this vector over and over and over and over. And that's why many of the scientists in the energy department and people like myself think that this was not an accidental evolution, from a bat to some unknown animal. We think this was an intentional research project to make a product that was going to be a public health good. All right, I don't believe there's any evidence that it was a bioweapon, but I do think it was a biodefense strategy.
Let's go to some questions. There are people standing around with microphones, and I ask that you speak loud and clear and announce your affiliation.
Yeah, I'm here at the Cato Institute. My name is McCluskey. I'm an economist for my sins. How do you think Sweden did?
I'll take that. First of all, it's an honor to talk with you. I read your books, like all of them. Anyways, the Swedish all-cause excess deaths is the lowest in Europe. Excess deaths meaning you look at the deaths that you would have expected from the deaths, every cause from 2015 to 2019. Compare that to what happened in the pandemic period, and they have, I think it's about 2 or 3% above what would have been expected from the data from 2015 to 2019. That's the lowest or the second lowest in all of Europe. That to me, I mean, that's one measure, but it's a pretty good measure of how well does Sweden protect the health of its population. They did it without lockdowns. They had some voluntary measures, absolutely, and of course they had vaccines. So you take that with what you will. What I take, at least one thing you can take from it is that lockdowns were not a necessary step to protect human life.
That's right.
Over there in the front row.
Marty Zupan, citizen. Jay, a question. I have two questions for you. Was herd immunity used, did you use that term in the Barrington Declaration, or was that something slapped on it by others?
No, we use the term in the Declaration. The reason, well, just the two reasons. One is that Sunetra Gupta is, as pointed out, a fantastic epidemiologist, and all the disease models, disease transmission models, have in them the idea of herd immunity. But so it's a technical term that Sunetra and we thought was important to tell the population about, in part to reassure the population, I'm talking like some high, to reassure people that this was a disease that did produce immunity, not permanent immunity necessarily, but like other coronaviruses. The idea of herd immunity in this context is not the classical herd immunity of you get measles or you get the measles vaccine, you're never going to get it again. Right? It's a very different kind of disease. You can eventually get, if there's a new variant. But the idea is that the spread of the disease, the ebb and flow of the disease over time is governed by what fraction of the population is, at least for that period, immune. And so the argument was we want to tell the population about it, not as a strategy, but as a biological fact about the disease. The analogy would be you're trying to land an airplane. And I've stolen this from Martin Kulldorff. If you land an airplane, you don't have a gravity strategy for landing an airplane. Gravity's there no matter what. The issue is, how do I land the airplane safely in the presence of gravity? Right. So there's a biological reality of this disease is governed, just like many other infectious diseases that have any immunity at all, by these patterns of increasing and decreasing immunity in the population. How do you manage population health in the context of that?
So my other question is for whoever has knowledge or expertise on this. I was really surprised by the short segment of the physician who said that intubating people and I can't think of the term right now, but that this was a perverse strategy. So, and you saw Cuomo saying we need thousands of these, not 400, and so on. At some point, that all went away. Is that because people woke up and they realized?
That's what happened. So sometime in June 2020, so in March of 2020, there were papers published in JAMA recommending intubation, in part based on what had happened in Italy.
Yeah.
Then by April, May, a lot. You saw that some doctor give some report about what was happening in his ICU. Those reports were all over the place. And by June, the recommendation was against intubation.
We rapidly moved to to trying to hold off on incubation at all costs, if possible. The other thing that's important that most people may not know is the COVID virus had a substantial transition in its replication dynamics in man. So the Wuhan strain, the UK strain, and the Delta strain all had a preference for replicating in the lower lung. And as a consequence, it caused inflammation in the lower lung, and as a consequence of that, it caused respiratory insufficiency. When Omicron came, there was a major switch in the pathogenesis of this virus. It no longer liked the lower lung. It now liked to replicate in the upper airway in the throat. And that's why, if you remember, when Omicron came, the real symptom was, oh, you have a sore throat, or you just have a sore throat, or you just have a cold. So it totally changed where this virus sets up shop. Most people don't know this, I think. We're trying to educate people that the COVID virus as a virus is not a lung disease. It's a blood vessel disease. And that's why it has preferential mortality and complications for those of us that are older, because our blood vessels are less resilient to take the insult of this virus. Remember the H2 receptor, which is the key receptor that this virus was educated to bind to, which I believe in the Wuhan laboratory, that's a key receptor in your blood vessel. That's what leads to microcoagulation, microfibrin clotting, You know, President Trump used to say, Bob, these people died of a heart attack or a stroke. They didn't die of COVID. And I'd say, Mr. President, they got a heart attack and they got a stroke because they had COVID, because their blood coagulation pathways are different. So a lot of people misunderstand that. Today, COVID is really not a significant lung disease. It really changed after the Delta strain.
You know, before we take the next question, I'd be remiss if I didn't bring this up because it was discussed in a movie. So last month, the Supreme Court in Murphy versus Missouri said that you and the other plaintiffs didn't have standing, and so they rejected the case. In the film, it's called the Missouri versus Biden because that was what it was originally called. Do you have any plans to relitigate this?
So they didn't actually reject the case. They rejected a preliminary injunction against the Biden administration going to social media companies and telling them who and what to censor, right? So the trial judge and the appellate judges had essentially told the Biden administration they weren't allowed to do that, right? The Supreme Court said that that we needed to have proof standing. In this case, what that meant was we needed to show some email that said, from some high official in the government to the social media companies, censor J, right? And there's not an email that says censor J. What there is emails that say that immunity after COVID recovery is misinformation. Censor that idea, right? So the case is going to go back down to the lower court. It dismissed the preliminary injunction, not the case as a whole. We're going to have more discovery. I have to say I'm quite discouraged by the requirement the Supreme Court has put on, even if we win the case, because if what's required is a email that if you've ever been. Anyone ever been censored by the social media? You have some label put on you or something? Yeah, you don't know that it's been done, why it's been done, right? So you don't have the access to the government emails that said that censor, Michael Cannon or whatever. So you just have to so you have no capacity to tell. And now the government what they can do is never mention a name. They can always just mention an idea, and no one will ever have standing to sue. That essentially makes the First Amendment unenforceable. It leads to a loophole around the First Amendment that needs to have legislative fixes. Apparently, the Supreme Court's not going to fix it.
Do we have any online questions, Agiva? Oh, you could read it. Oh.
Okay. Some scholars say current ethics of research on human subjects unduly blocked research. For example, voluntary experiments in variolation under medical supervision. Voluntary experiments about viral transmission mechanisms. Are constraints on such voluntary experiments justified?
Okay.
I didn't really understand the question.
I'll take this. I think this has to do with intentionally infecting people to see if some treatment works or a vaccine works.
A human challenge
kind of ideas, right? Okay, so I don't want. I'm just going to stay out of the ethics of this because let me do a punt, which I think is a relevant punt. To me, the most important thing about this disease is that it really, really, really hurt older people, right? That's the most important thing about the disease. And so I don't see how one could have done a human challenge trial in young, healthy people and then necessarily extrapolated whether it's beneficial in old people, whatever the treatment that you're trying to do. The problem to me wasn't the lack of patients that were being infected. There were tons and tons and tons of patients being infected. In many cases, what you're doing when you're studying medical treatments of things, the problem with trials is you don't have enough patients to find for the diseases you want. Here you had millions of patients. We just didn't use the risk of the disease in a systematic way early enough to test all of the treatments that we should have been testing early. That's the problem. So, I think we didn't, the discussion over the human challenge trial is interesting ethically, but I think practically what was needed was a concerted effort to randomize patients for the treatments of the disease early. We did a great job organizing, the private sector did a great job organizing the randomized trials, and not just in this country, country after country after country for the vaccines, but we did not do as good a job as we should have on the randomization for the treatments early on.
Any questions in the room here? Row 2, right?
Hi, my name is Bruce Blumenthal. I'm a family physician in Baltimore, Maryland. My first comment and then a question is to really just thank Dr. Bhattacharya in particular for his work and those of his fellows on the Great Barrington Declaration, because it allowed people like me who are not so well-known nor so as educated to express our own skepticism to our patients and to fellows in the community who actually just smashed us for doing it in many cases. But it gave us some credibility because there was good reason to be skeptical about what was taking place. But my question for the panel is, how does the public health community, the NIH, the FDA, the CDC, and other scientific organizations now regain the confidence of a justifiably very skeptical public?
It'll be very, very difficult. And I think it's the real cost, really, of the decisions that were made. As I said before, I think, mandating something to somebody who's made a decision, they don't necessarily want to do that. I don't think that's useful from a medical or public health point of view. That just reinforces the skepticism. So I think these CDC, which I ran, I think NIH, I think the FDA, I think they're going to have a hard time regaining that, which is, your question is so important because it's so fundamental to being able to implement public health, is you have to have public trust. And I think what I tried to do with my colleague Tony on many occasions when we were in the room, and I would answer, I don't know. And I remember on herd immunity, Tony said, we'd have herd immunity when you were at 30%. And then about 8 weeks later, he said 50%. And then a couple weeks later, he said 70%. And the reporter was pretty smart. She said, Dr. Fauci, last time we talked, you said it was 50%. Why do you say 70% now? What did you learn? And he said, oh, no, I didn't learn anything. I just knew when I said 50%, you weren't ready to hear 70%.
See, that's the kind of thing that,
And that really destroys public trust.
yeah.
Can I say one thing on your behalf, Bob?
Go ahead,
also,
please.
also in front.
I'd like a
Francis.
couple things on my behalf.
Yeah, because I like, and also on Francis Collins' behalf, your willingness to say, here's what we did wrong and here's what I did right, is really, really fundamentally part of the answer to your question, right? I think, honestly embracing the fact that how could you make all the right decisions in the context of this virus? There's not possible, right? So I think that honestly embracing that, saying the I don't know in retrospect also is part of that, and humility, engaging the public. I think that's going to be part of it. It may not be all of it, but certainly part of it.
And it's also the notion of the noble lie, which makes, I think that's tied to the reduction in young children getting vaccinated now, because I think a lot of people just are no longer trusting anything they're hearing from the public health
But
community.
when I was CDC director, I had some schools in Texas that less than 25% of the kids were vaccinated against polio and measles.
Ryan, you want to say something?
Yeah, no, I mean, in the country that I'm from, the UK, there's currently a big public inquiry going on into the pandemic, and, how useful it will be is an open question because it's got quite a tight remit. It's not really supposed to look at the costs and benefits of decisions. But one advantage of it, and one thing that I think positive could come out of it, is that just the sheer release of information gives us much more of a steer on how decisions were made. And I think Jay's point here is absolutely right. With this degree of uncertainty and with everything going on and with new developments in the virus or whatever, you can't expect nirvana. You can't expect that public health officials are going to make every decision right. But it'd be really useful to understand how decisions were made, what sorts of factors were, behind, how far were trade-offs being analyzed in making some of these judgments.
I mean, I read the Matt Hancock's WhatsApp emails or messages with great interest. I mean, I think they like people just to try to be somewhat forgiving.
Well, I think the real problem was there was not an atmosphere to have really public debate and discussion among us as colleagues. I mean, I've said this publicly, so it's no surprise. I was one who felt that, as a virologist, that this virus, if it went from a bat to some animal to a human, like SARS and MERS before it, one thing that those viruses had in common is they never learned how to efficiently transmit human to human. All right, so we've had less than 10,000 cases of SARS since 2003. It just never learned how to do it. MERS is the same thing. This virus immediately was one of the most infectious viruses known to man, all right, probably right behind measles. And we had articles published in 2014 from the lab that showed they successfully taught this virus how to infect humanized mice through the H2 receptor. So it was actually published that they did it, what?
2018.
You know, it's 3 or 4 years before. So I concluded as a virologist, clinical virologist, that it was nonsensical that this virus went from a bat to some animal we can't find. No, I think this virus was educated to how to infect humans, and that education turned in the lab. It is interesting, if you take COVID-19 now, and you ask it to infect a bat, it hardly can infect bats. So how does this virus, supposedly, I can tell you MERS knows how to infect bats, so I just think it really was, but when that debate happened, and I told Tony, you know, that was my position in mid-January, and I really felt we had to go after both hypotheses aggressively, and I thought him and Collins ought to lead aggressive, transparent aggression into both hypotheses, and I'd be happy to be on whatever panel he wanted, okay, either the lab or the natural origin. We should have a scientific debate. And then Jeremy Farrar arranged that teleconference on February 1st, which I still believe Fauci and others had a hand in who was on the call. And I know other people were added because Collins wasn't on Farrar's list, but Collins was added to it. I criticized Tony for not having me on the call. I mean, I was only the CDC director, all right? And I wanted to be on that call. And I was told by a colleague that was involved in this that the reason I was excluded, that the group had decided that they'd have one point of view at the end of this, and they were pretty confident that I wasn't going to change my point of view, so I was excluded. That's not the way science works. We have to have honest, open disagreement. That's why your movie's very good about truth and discussion and openness. You know, we can be of a different opinion. And let me make the argument, if I had been on that call, I would have made the argument for laboratory spillover. The other people who thought it was spillover, but 3 days later they all changed their mind, I don't think they were as rock solid in their understanding of the origin of this virus. And I think that's really sad that we can't have honest, open, same thing with the Barrington Declaration. That should have just been debated openly, not name calling and not getting deans to try to, you know, kick people out of the university. We should have just argued about it.
But interestingly, if you go back to like April 2020, there were some economists, Darren Acemoglu, you know, fated economist, like a lot of people think he's going to be a Nobel Prize winner in the future. He wrote a paper, a working paper for NBER, advocating a variant of the Great Barrington Declaration strategy. But so at that stage, there was some debate, and it was acceptable. But after the first lockdowns were released, it seemed like it was just anybody who said anything different was persona non grata.
I'll tell you, it's the least original thing I've ever worked on in my entire life. It's just the old pandemic plan. I mean, like, it's not surprising that in February 2020, you had Mark Lipsitch writing op-eds in the Washington Post advocating for something that looks just like the Great Barrington Declaration.
You may recall we had an online event about 2 years ago about lessons from Sweden, because we were already getting some very positive results from Sweden. And Cato Senior Fellow Johan Norberg was on that conference, and he said, in Sweden, we were thinking that the rest of the world are outliers. We were just following the routine playbook.
Right.
I mean, this is like, I see Anders Tegnell, the Swedish public health director.
I'd like to make one comment if I can.
Sure.
Or you want to? I want to make a comment because I think, again, very well done movie, and I think
Thank you.
your two lines are really important. One was the lockdown, and an honest discussion of the cost of that, and how that, and the other, of course, was the origin. And the one I'm more engaged in is origin. There's a lesson with origin, and this is what I've tried to articulate and will continue to try to articulate. The lesson from origin, and why I keep saying origin's important, is because the origin, from my perspective, came from scientific research, from gain-of-function research. In other words, this pandemic was a consequence of science, right? And science has to come to grips with that, right? And people know that I'm very concerned of what I call the great pandemic. I consider the COVID as the lesser pandemic. The great pandemic is the bird flu pandemic. And bird flu needs to go through 4 amino acid changes in its receptor to gain tropism for humans. And that's a pretty high species barrier. So it could take a long time. Some people think it would never happen. I'm a little nervous in that it's trying, because it started in chickens and turkeys in the United States in 2019, and now over 100 million of our chickens and turkeys are infected. So it's a big deal, all right? And it's now moved into 27 mammals in the United States, including things like dolphins and seals and cats and mice, bears and cougars, and as you know, most recently, dairy cows, all right? So it's trying to learn how to go into new species. It still hasn't learned, though, how to go mammal to mammal. But if I take that virus into the laboratory, I can teach it how to do it in weeks, all right? And that virus is currently in university laboratories being manipulated so it can gain human tropism. So this is why in my Wall Street editorial, I've argued, and I will continue to argue, and I testified 2 weeks ago for the Senate, that we should have a moratorium on gain-of-function research. I'm not anti-science. My parents are scientists. I love science. But I don't think society should have a broader debate about the value of gain-of-function research. And if society thinks we need to do it, then how do we do it in a safe and responsible and effective way that doesn't threaten our national security? But right now, it's the gain-of-function research that could lead to another pandemic. And don't kid yourself. I think the scientific community is defensive. The COVID pandemic was a direct consequence of scientific experimentation by scientists. It wasn't a consequence of nature and evolution.
Bob, was it not only the pandemic was not only a result of gain-of-function research, but also the issue of the Chinese lab not having a proper biohazard?
No doubt about it.
Where the lab, I believe, is classified as a level 4 biohazardous lab.
Yeah, but it was functioning at level 2.
And for years, and my understanding is that the FBI and
State Department
and Peter Daszak in the film were aware of the carelessness within the Wuhan lab.
Everyone, the state,
the
yeah.
security carelessness, and that it was assessed at a level 2 biohazardous
There's a
lab.
declassified State Department stuff from several of them showing in 2021, I think in 23, that the lab had significant containment issues. Biocontainment is one of the things we need to do. But I will tell you, the biocontainment required to do this work safely. When I was CDC director, one of the things I had to do, which was not popular, and I got myself on the Washington Post again, was I shut down Fort Detrick. Now, I was in the military for 23 years. These were my friends. And they had a lot of important experiments going on. But CDC inspects all these labs, okay, and when all the containment labs. And when we inspected them, they had some defects in their containment policy. So we went back the month later and inspected again. They hadn't corrected them. And some people said, well, you don't really want to shut them down. It's 14. No, I'm shutting them down. I told the commander, was a friend of mine. I called him in. I said, well, we're shutting you down. This is not a game. You're dealing with some very dangerous pathogens here. We owe it to the people of Frederick. We're going to shut you down. You need to correct these defects. All right? I mean, they had some significant defects, including where the sewage was going out of the lab. All right? So you're exactly right, but we do not have that I can go into any university lab across this country right now and inspect them. They do not have the containment that they need to have. So biocontainment has to be a priority, and I would argue there's only going to be a handful of labs that are going to be able to maintain the redundancy of that biocontainment to work with P3, P4 respiratory pathogens. They're the hardest pathogen to contain.
Can I give you one more data point on that? In 2021, in Taiwan, there was a lab, a high-security lab, working on the SARS-CoV-2 virus, the COVID virus. And there was a lab leak in 2021 in Taiwan that caused a local outbreak of the COVID virus. And they knew how infectious it was. I mean, working on these kinds of pathogens in labs is inherently a leaky activity.
It's hard.
Right? And so like scientists that come and tell you, oh yeah, we know how to contain this, we are going to do this safe 100%, they are lying to you.
But I mean, just to ask you guys a question, because I'm generally ignorant on this. I mean, isn't not a bit like AI development? Like, what are the prospects? This is a global potential externality problem, right? The costs of a great pandemic would be huge, but you need international buy-in across many countries. I mean, how do you get to a stage where you have an international agreement that no country is engaging in gain of function?
We already have an international bioweapons convention that prevents every country that's a signatory,
Which this lab was part of and violated, if you talk to Dave Asher. I mean, they were in the State Department. They violated every time. You know, that's the argument against me. Since we can't get everybody to do it, let's not do it. I think we start by getting our act together here and doing it correctly. I would argue, and again, I'm not trying to be political, I would argue that the world would be a safer place if we would spend more attention on biosecurity and containment labs than climate control, okay? And that one's a much more immediate threat, right? And, you know, I have 14 grandchildren now. I think it's very probable that they're gonna have to live through a significant viral respiratory pandemic, which I think, and for those of you who think I'm exaggerating, some people get mad at me, you're scaring people. I'm not trying to scare people. I believe in the power of science. I believe that we can get through this. But read The Great Influenza by John Barry and get a sense for how just a simple influenza virus, you know, that was originally the Spanish flu can come. Right now we've had 888 people that have gotten H5N1, which is the current bird flu virus, since 2003. In the world. And of those 888 people, 52% of them died. This virus is nothing like COVID. Now, I assume it will lose pathogenicity as it learns how to transmit in humans, but this is not going to be a COVID virus. This is going to be much more significant, and we ought to do everything in our power to not help create it.
I think that's a good note to end on. We're out of time.
Positive note to end on.
I'm getting a little hungry also. So I want to thank our guests. This is a fascinating discussion on a great film. And please join us in the Winter Garden for a reception now. Thank you.